Hi, my name is Elizabeth Campbell. I am a physical therapist with Limitless Physical Therapy here in Cortland, New York. I am a pelvic health physical therapist for females and males, as well as an orthopedic and sports physical therapist. This presentation is going to focus on urinary dysfunctions and the role of pelvic floor physical therapy as it relates to females. A little bit about Limitless Physical Therapy. We are new to the Cortland area, recently located here this past November. And we are on an exciting mission to help and grow a thriving community, working to inspire the best possible health outcomes. And we are doing so with a wonderful team here in the office, providing orthopedic, pelvic health, sports rehab, as well as some vestibular rehab. Today, our mission is to review and discuss some different bladder conditions as it relates to pelvic health. Because the reality is that 1 in 8 adults, men and women, will experience pelvic floor dysfunction in their lifetime. And there's a lot of there are many questions that circulate around what pelvic floor physical therapy is. And really what we are is it's rehabilitation that focuses on addressing symptoms of the pelvic organs and the muscles and structures that make up the pelvis. One extensive structure being the connection of muscle and tissue, which is the pelvic floor. So in addition to addressing symptoms and impairments of those organs and tissues, we also are really focused on optimizing the individual's strength, mobility, and really just those foundations of health and wellness. Because again, our vision is beyond just that immediate impairment and this big, broad scope, improving people's wellness, improving our community's wellness. So the intention of these presentations is to take one step in that direction and bring some education to both providers as well as the patients they might be interacting with on a day-to-day basis in their clinic. So we're going to discuss what some of these urinary dysfunctions are, some of the physiology or cause behind them, what contributes to them, and what the role of pelvic floor PT is, and what pelvic floor PT looks like at Limitless if you were to walk in the door and have an experience. So the occurrence here of pelvic floor dysfunction as it relates to bladder symptoms is really significant. This is one of the most prevalent conditions for which we see patients in our office. So our patients range from our pregnant and postpartum women to more of our senior males and females, and down to some high school and college athletes. The rates of occurrence are pretty high across the board, where we see about 40% of pregnant people experiencing urinary dysfunctions, about 40 to 50% of adolescent female athletes experiencing urinary dysfunctions. And then we see a pretty significant correlation as far as the occurrence of urinary dysfunctions in those who have had a vaginal delivery, who are obese, and those who experience symptoms of anxiety and depression or kind of have an altered mood state. So this is a very prevalent condition. It's not isolated to just women, and it's not isolated to just one or two specific age groups. This is really broad spectrum, can impact women across all stages of life. So micturition is the fancy term given to how our bladder kind of stores and voids urine. And this is an important mechanism to understand as it relates to some of the conditions we're going to review. So at the very top of this image is an empty bladder. And you can see the extent of the full bladder with the urethra descending down from the bladder, and then the pelvic floor muscles where they kind of come in and interact with the urethra. This is by no means a perfect picture, but it's a nice image to represent. But essentially, the bladder is never really truly empty, right? But as it fills, the bladder expands, right? As you're drinking and eating throughout the day. And once the bladder becomes about halfway full with about 250 milliliters of fluid, the bladder will communicate to the brain, and there is what's called the first urge or the first sensation to void. And what should and does occur is that the bladder kind of or the brain talks to the bladder and says, well, you're not all the way full, you're about halfway full. And so that urge is suppressed and you continue to go on about your day and your activity until the time comes when your bladder reaches about 450 to 500 milliliters of fluid, is when you have that second true urge that is communicating to your brain saying, I am at my capacity. Then your brain tells you, yes, you are full. Let's make your way to the bathroom. And then when you sit down, you choose or make the decision to void when you want to void. There are some general norms for the average adult who consumes that recommended 60 ounces of water a day. So for males and females, average is between 6 to 8, sometimes 6 to 10 voids per day, depending on how much water you're taking in. And the average nighttime void can be anywhere from 0 to 1 time a night, waking up to go to the bathroom. Or if you're in that age group of 65 and older, it could be 0 to 2 times a night waking up. And that all fits within those kind of normative values. In general, the bladder could kind of hold upwards of 3 to 4 hours worth, right? That's kind of that maximum capacity to hold urine before having to void. And you should be able to initiate your stream, maintain a steady stream, and feel pretty complete when your stream is done. There are some norms as far as the volume of urine that you void. This is best measured using a urinal or what's called a hat that is inserted into the toilet, which would allow us to capture exactly how much urine you are voiding when you are going to the bathroom. So some specific dysfunctions, or some of the most prevalent dysfunctions we see individuals in the clinic, are urinary frequency and high urgency, meaning people feel they have to go a lot or go all the time, or urinary hesitancy and retention, meaning someone could go the whole day and really not feel like they have to go to the bathroom that often, maybe 1 to 2, 2 to 3, 3 to 4 times. And then incontinence, and we're going to unpack the different kinds of urinary incontinence. But urinary frequency is really when someone is voiding 10 or more times a day, and they have likely developed patterns such as second void syndrome, meaning they went to the bathroom and peed, and then maybe 5 or 10, 20 minutes later, they have another urge to go, and they go to the bathroom to void again. Or they can have triggered voiding, which are kind of sneaky little patterns and behaviors that develop over time. And before you know it, when you hear water, touch water, when you walk through the threshold of your doorway, or when the car pulls into the driveway, right? You have this sudden, intense urge to go to the bathroom, and it is a race to get there. Some other triggers some patients experience is getting to a store and feeling like they need to locate and go to the bathroom right away, or knowing they have to go travel in the car, and before leaving the house, they have this high sudden urge. Or repeat voiding before nighttime. So some patients may feel like they can't go to sleep without voiding 4 or 5 times in a row to make sure everything is out. So that's on one end of high frequency. On the other end is urinary hesitancy or retention, meaning someone is going a very few number of times per day. Maybe they have difficulty initiating their stream. Maybe their stream is not steady. It starts and stops, starts and stops. And maybe they feel like they have to push or exert some pressure downward in order to get their pee to evacuate. And then the last kind of cohort of symptoms is incontinence. And there's really a couple different kinds of incontinence for which we'll evaluate patients for. So there's stress urinary incontinence, which is the involuntary loss of urine during physical activities that increase abdominal pressure, or during quick bouts of quick increases in abdominal pressure. So think sneezing, coughing, yelling, laughing, all instances where abdominal pressure downward is going to overload the bladder and all of your continence systems, like your pelvic floor and your sphincters, and you can experience leakage. Then we have urge urinary incontinence, which is essentially that uncontrollable need to urinate, right? It is an emergency to get to the bathroom, and you have accidental leakage that occurs on your way to the bathroom or as you're sitting down onto the toilet. Functional urinary incontinence is essentially when a person is aware that they need to get to the bathroom, but either due to physical or mental limitations, have a hard time executing. And then lastly is athletic urinary incontinence. This is when an individual experiences leakage only during athletics and sports. Not really otherwise experienced or noted with their day-to-day activities. So if someone is experiencing any range of those symptoms, PT or pelvic floor PT is indicated and can be incredibly helpful. And when someone like that comes in the door and sits down for their evaluation, we're going to spend a lot of time kind of unpacking their symptoms and getting to truly understand the singular components or the multi-components of what they're experiencing. So we're going to do a pretty extensive history taking kind of interview or consult. We're going to go into an orthopedic screen of the back, of the core, of the hips. We're going to go into specific physical movements, right? If those are the things that elicit their symptoms, then I'm going to have them do that in the clinic in real time to see, what their endurance is, what their threshold is, kind of where we're starting out at, what their baseline levels are. And then we'll go into a bladder assessment, which is kind of our first look at the pelvic floor using rehabilitative ultrasound, where we can get just a picture of what pelvic floor activity they have, how pelvic floor activity relates to their breathing cycle, what their volitional or their ability to contract those muscles is like. what their endurance is like, what their coordination as far as the contraction and relaxation capacity of those muscles are, and just how they relate to their bladder. And we'll just see if there's some indicators that, yes, the pelvic floor is a component. And in which case, if we are led in that direction, then we'll talk about the next steps of potentially performing an internal pelvic exam. So in addition to those more hands-on exam pieces, we're also going to get a really good idea and picture of this individual's kind of lifestyle and what their current patterns and practices are. So most of the patients are sent home with a bladder diary, some water tracking instructions, and a food diary that also tracks their bowel health. So why are some of these things in the exam indicated, and why are they important? So first and foremost, across the board for really all of our bladder conditions, getting a good idea of what an individual's fluid intake is like is incredibly important. What the behaviors are like around voiding relative to how much they're drinking, what kinds of things they're drinking is going to give us a really good picture potentially of some cause and effect, and then some immediate cues and education for intervention. What the diaries also give us, and our subjective also gives us, is a really good idea of some behavioral patterns that we might be able to adjust and retrain. Again, some of these behavioral components, like the avoiding triggers and the urge triggers, these are kind of sneaky things that just slowly become the norm for patients. So if we can, A, bring attention to it, and then B, give some steps to address it, we can see a lot of symptoms of urgency and incontinence come way down. For high urinary frequency, the other things we want to assess are pelvic floor muscle function. So on a pelvic floor muscle involvement, pelvic floor involvement is really on a scale across some of these conditions. In patients with high urinary frequency, sometimes we can have really high muscle tone and capacity that almost creates a little bit of stimulus or irritability or sensitivity along the urethra and the bladder, and this can trigger or stimulate urge. So we'll want to try to identify that either through ultrasound or a direct hands-on evaluation. At the same time, we're kind of taking into account the neuromuscular function or nerve function. So sometimes when there's an environment of irritability along the nerves within the pelvis, that can also feed into a more reactive bladder and more sensitivity along the urethra, thus contributing to higher urge sensation and higher frequency. And then we want to get a good idea of an individual's bowel function. We see this a lot, that when patients have impaired bowel function, that is going to feed forward into the pelvic floor and impact someone's continence system, sense of urgency, or sense of pelvic pain. When it comes to urinary retention, or the patient's inability to void when they want to void, or difficulty in doing so, a big piece we want to take into account are their behavioral patterns and their work schedule and just their day-to-day schedule. So individuals whose time is kind of not their own, meaning they can't just go whenever they want to, will tend to develop these patterns of long bladder holds, and then soon they kind of lose the sensation of an urge, and before long they're holding their urine 6 to 8 hours before thinking like, oh, I should probably go to the bathroom. So these are things we want to call attention to. And then we want to definitely call attention to mood state. So what is their mental and emotional stress levels? Do they have some anxiousness or some anxiety that might be creating a little bit more of a hyperactive state, we'll call it, in the pelvic floor and in the pelvis, thus triggering or causing the inability to relax and release and to allow urine to be voided. That kind of plays into the different nervous systems that can control our pelvic floor and our sphincters and our bladder and bladder musculature. In the realm of incontinence, so the role of physical therapy for stress and both urge incontinence is going to really be dependent on an individual's symptoms. So we're going to follow that ultrasound exam. And if that leads us to indicators to do a pelvic floor assessment, meaning an internal pelvic exam, then we will want to do that very specific hands-on assessment. This is going to give us a good idea of what the muscle state is like as far as the tissue and the tone, what the muscle contractility is like, what the coordination is like, and just what the behavior, the timing, and capacity is like of these muscles under different kinds of loads and stresses. We're also going to spend time addressing the core, the spine muscles, and the hip muscles, and just building general movement capacity. We'll often see patients come in with symptoms of urinary leakage who don't jump or run anymore because of those symptoms. But the longer they stay away from doing those movements, the higher likelihood that they will have of continuing to experience those symptoms of leakage. So what we need to do is train up the muscles and the hips and the torso to withstand those kinds of loads so that our individuals can get back to the physical movement with their kids or with exercise that they want to. So that is a big piece of addressing stress urinary incontinence, whether that is specifically the component of coughing, sneezing, laughing, or that athletic incontinence that we noted earlier. And then with urge urinary incontinence, this is really just a big piece of making individuals aware of their triggers and behavioral components and retraining some physical movement patterns and just building resiliency, building good load tolerance to decrease that kind of sensitivity and kind of irritability that can be occurring within the pelvis. All in all, both of these diagnoses or dysfunctions are things that respond really well to pelvic floor physical therapy and progressive loading in pelvic floor PT. So I hope that was a helpful little glimpse. It's definitely wasn't all encompassing as far as urinary dysfunctions, the different types, and all the full extent of pelvic floor PT, but it just gives hopefully a little glimpse into pelvic PT 2.0 and kind of how we're trying to raise the bar for our patients and address their symptoms, but improve their wellness and their overall physical capacity for long-term health and longevity. So if there are any questions, please do not hesitate to reach out. We have providers in Rochester. We have providers here in Cortland, New York. We are a phone call away for questions from providers as well as any potential patients. But I thank you for your time, and I hope you found this very informative.